Hub, Charity Yawa, you are welcome.
Thank you.
Welcome. Solwezi General Hospital, you are very much welcome. Welcome to this afternoon's session. So, to moderate this session today, I'm Dr. Peter Matibula, joining you from the Hub at UTH. In the Hub, I'm joined by our coordinator, Etambuyu, and also our well-able IT, Kote and Chatonda. Right, so also joined by our subject matter expert for today. Welcome, Dr. Chimika Phiri. You're very much welcome to the Hub. I would also want to welcome the panelists that will be joining us for this afternoon. Thank you for taking part in this session once again. Mr. Peter Funsani, you're welcome. Mr. Chimuka, Sianyinda, Mr. Andrew Banda, Dr. Sulani, Nyimbili, it's good to have you again. Mr. Jacob Mutale and Dr. Kalubula Maybin. You are welcome to this afternoon's session. Colleagues, just a reminder of the echo etiquette. Please remember, once you join, remember to unmute your mics to avoid any background disturbances or noises. And also, if you have a question, contribution, or also remember to raise up your hand through those echo icons that are down there. Right, so without wasting much of the time, I'd like to call upon Dr. Chimika Phiri to go on with today's session. So today we are looking at a very important topic to do with data capturing. So we're looking at best practices in data capturing for decision making. Right, so just to repeat that again, where today's topic is best practices in data capturing for decision making. Very, very important topic for this afternoon, which borders really on how we collect data, and we should make use of that data. So without wasting much of the time, I welcome Dr. Chimika Phiri to start with today's presentation. Dr. Phiri, you are welcome, and you can go ahead.
Thank you very much, moderator, and good afternoon, network. As Eddie indicated, Dr. Chimika Phiri. So I'll take you through today's topic, where we'll look at the best practices in data capturing and used for decision making. So I have no disclosure of conflict of interest to declare. Okay, I hope the network is able to see our presentation. Yeah, so as I earlier mentioned, I've not nothing to disclose or indeed conflict of interest to declare. So these are the learning objectives for today's discussion. So we'll look at the role of data in decision making for action, and also discuss common pitfalls in data capturing that usually noticed in the facilities. And also, we'll further look at the best approaches that we can use in during capturing of the quality data. So, as you noticed earlier on, I'm the HIV CaseBased advisor, and people may be wondering, how do we come in with the topic of the best approach in terms of data capturing? So, just wanted to give you a synopsis of what HIV case-based surveillance is. I know quite a number of people on the network may be familiar with it, but nevertheless, for the benefit of colleagues that may be hearing about this program for the first time. So this is the Ministry of Health program, and HIV case-based surveillance basically refers to systematic reporting, analysis of standardized information that is about cases that are diagnosed with HIV to an agency. In our case, we're talking about the Ministry of Health, for the purpose of HIV prevention, control, and action. So you see that our work is around data. So under HIV CBS, each individual that is living with HIV is actually reported as a single case report containing information pertaining only to that individual or that person. So in other words, HIV CBS monitors the entire spectrum of the disease from diagnosis to death. In simple terms, our program tracks the life of an individual from the time he or she is diagnosed with HIV until death. So we track specific events in his or her life. So just to summarize some of our major program focus under Ministry of Health. So CBS is involved in the analysis of the case-based surveillance, which is deduplicated and longitudinal individual level data in order to provide current HIV epidemiological profile that can be used for decision-making and also to help program management. It's also involved in capacity building. We target health staff across the country so that we improve or capacity build in basic data analysis at sub-national level. And also we have a mandate to create data demand and use both at national and sub-national level. And this is part of the activities that we are doing today to ensure that we create data demand and use. So part of the approach we use is such a forum like this one where we share some of the best practices in data management. And also to provide analytic support to program teams at MOH. So CBS team started analyzing data, and soon many of us will be able to appreciate some of the specific indicators under HIV program. We also endeavor to collaborate, work with our key stakeholders, both internal and outside. These include the M&E colleagues, and this is why if you look at the expert panel, we have a team from MOH and also UNZA and also CIDAS. They have a strong background on M&E, the IT, and also the program officers and other key stakeholders with the purpose of to improve data quality. And this is exactly part of the objective for this presentation, what we are doing. So maybe we start with.
All right, so we pause for a poll question before we dwell into the matter of this presentation. So just allow me to launch the poll. Okay, so the question reads, which of the following is true about data quality? Is it A, data accuracy and completeness are important features in paper-based only? Is it B, data quality is more important for program improvement than tracking disease trends? Or is it C, data quality issues includes calculating errors, late reporting, and over-reporting? Or is it all of the above? I'll read it again. Which of the following statements is true about data quality? Is it A, data accuracy and completeness are important features in paper-based only? Or is it B, data quality is more important for program improvement than tracking disease trends? Or is it C, data quality issues includes calculation of errors, late reporting, and over-reporting? Or is it all of the above? Okay, so we're having responses so far from the network. The majority so far is going for C, data quality issues includes calculation, errors, late reporting, and over-reporting. Right, so I'll just give it a few more seconds for most of the people on the call to respond to the poll question, and then I'll end the poll and subsequently share the results. Okay, so just a few more seconds for people from Solwezi General to respond to the poll, then we'll end it. Okay, so we have more than 50% of the network who have responded to the poll. So at this point, I'll end the poll and share the results. Okay, so there we have it. So the majority, really 51% of the network feel that C is the correct answer. That is, data quality issues includes calculation errors, late reporting, and over-reporting. Right, so I'll hand it back to Dr. Chimika Phiri to give a comment really on these results. Is the majority of the network correct to say that is the
yeah, interesting pause there. So in terms of when we look at the meat of the discussion. Yeah. All right. So thank you, network, for those pauses. So just to remind ourselves that where does this data that we are talking about, where is it generated from? Where does it come from? So in the pictures there, these are data sources that we are all familiar with. What is being captured here are two data sources. So we have the electronic platform, the electronic health records, in which case, in our case, is smart care. You can see hardworking lady there looking at the desktop, making some interactions in the electronic platform. And on the other side, you can see well-populated paper, that is the paper source. So we have paper and electronic, and I'm sure we can relate to wherever we are sitting or we are working from our workstations. Some stations pure electronic, others have pure paper, others have a mixed type. All right, so this slide just reminds ourselves in terms of how does data flow under Ministry of Health. So from the source where it is generated, which is at a facility, at a client level, the records are produced, and then they have to find themselves up at national level. And each of us at different levels of responsibility to ensure that this information reaches central level. So the Ministry of Health actually organizes this data flow via HMIS, and then later is organized in the DHIS database, which many of us are familiar with. Can move to the next. So this also depicts in terms of the electronic flow of data. I think it's almost the, it talks about where this data is entered from. So many of us that have used smart care, you can see that in all service points, we're supposed to be connected. We're supposed to have a computer or indeed any gadget that should allow us to enter information electronically. So it's not exhaustive, but it represents where at the facility information is generated. And indeed, you can also see that we can interact with the class at community level. However, at the end of the day, this information is gathered. At each point, there should be verification, cleaning, deduplication, and also triple analysis, and feedback should be given to the lower levels. And this is exactly what we expect at each of these levels to do. So what is data quality? Okay, when we talk about data, what should come across in our mind? We should think about data quality. So in simple definition, this defines or refers to features and characteristics that ensure data are accurate and also complete, and that they convey the intended meaning. So as we generate this data, let's think of what are some of these features. Are we making sure that these features and the characteristics of the data that we are inputting, okay, is accurate and also is complete? In other words, it refers to the degree of excellence of data. I must emphasize that this is very important because we should understand that data of high quality actually improve the intended use in many operations, in decision-making, and indeed planning. And these are important attributes that we need to ensure that they help with the quality data. Let's quickly look at what are some of the key principles of data quality. Okay, so we have about 6 key principles. So we have precision, reliability, validity, integrity, completeness, and timeliness. So what do we mean by precision? This means that the data that is collected and analyzed should be able to be interpreted at an appropriate level of detail for it to give us the appropriate response to the questions that we may have. Okay. Reliability, this refers to, in terms of the data that has been captured, if we do some repeated measures of a variable, okay, that have the same results, the data should be consistent, okay? And this is taken care of whenever we are designing a data collection tool to ensure that the data that will be captured is reliable. Validity, okay? This refers that the data that we have captured is actually measuring what was initially intended and indeed what is intended, and you are getting the type of response that is expected. Integrity. This term, I'm sure we are familiar with it. This defines that data should be accurate from the time it is collected and throughout the data management process, which in other words, throughout the reporting cascade. So data integrity should be one of the songs that we should have in our head. Completeness. This is one of the issues that the HIV CBS is struggling with in terms of the data that we're pulling. So in terms of completeness, what it means that all the intended data that we are expected to input or provide should be collected. And I must mention that many of us, we are familiar with the smart care, especially if you are providing services to individuals living with HIV. During the clinical follow-up, many of us do shortcuts because we don't populate at every section. But remember, completeness is one of the key principles of data quality. It means if you're not completing all the fields, you are not providing quality data to the Government Republic of Zambia. Timeliness. Data in terms of a collection, entry, and submission, and its use should occur at appropriate frequency and also at appropriate schedule. Okay, so what we mean here is that whenever data is requested, it should be available at all time. And this is where we have some schedules that all of us are familiar with when we are supposed to report specific type of data, all right? And some of the data is reported at different frequencies, and that has been kept standard. This is important so that whenever the agencies or the Ministry of Health wants to look at certain variables, the data should be available. So timeliness is key. We can move on to the next. So why should we be talking about data quality? Why is it important? Okay, so you can see that there are various levels where we need to use data. So data quality is important in terms of reporting and accountability. And under HIV program, we receive a lot of support from different donors. And these resources, we need to be accountable, and we can only be accountable by providing quality data, because as many of us are aware, we always have plans in order to reach certain targets. And how do we measure? We need quality data. Resource allocation, this is important because we need to use the resources available in a prudent manner. And the data, and indeed quality data, needs to guide us in terms of where really the gaps or the challenges exist so that the resources are prudently allocated. Program improvement, I think this is very important. We need data for us to see where we're having gaps and indeed to provide a check whether we are in the right track, achieving our objective. So quality data is key here. Disease trends tracking, right now we are talking about how we are performing in terms of HIV cascade. For us to talk about the 1990, now we're talking about 95, 95. We can only talk about it if we look at our quality data. Program and policy decision making. At policy level, they need quality data. And I know many of our colleagues here that have participated in various activities around planning at national level, even at sub-national level. What is key there is, do we have quality data that is going to help us project and also look at where we are? And this is very important because policy decisions can be made based on this quality data. All right, so having spoken about the importance of quality data at different levels, these are some of the data quality issues that we need to be familiar with. So this includes over or under reporting. So when you over report, it's a problem. Under report is a problem. So what we expect from all those that have been given a mandate to report is to report what you are expected to report on. And also poor quality control, omissions, double. Some of these things, we'll look at them further. Calculation errors, okay? Colleagues that are involved in R&R or report and acquisition, you know that many times some consumables may not be enough because we underreported, or in calculating, we didn't submit the correct amount that we needed. We did under projections. Changing of reporting formats, this can also bring issues. Unsystematic data collection and reporting, late submission, remember timeliness, and lack of supporting documents at all levels. This is where, again, we need to ensure that supporting documents are available. Data disaggregation in inconsistency reporting periods. So we'll strive to look at some of these in detail in some subsequent slides. So what are some of the reasons of some of these issues that we spoke about earlier on? Because all those quality data issues contribute to poor quality of data. So the first one, lack of proper data management. Okay, this may happen where we don't have unclear, okay, where we don't have standards, or even when they are available, they are very unclear in terms of the SOPs. Okay, so at every point where data is collected, there should be clear SOPs so that whoever comes through understands what exactly is supposed to be inputted and in terms of when it's supposed to be reported. Okay. Also, if there's no clear communication in terms of reporting periods, again, this also speaks to SOPs. Whoever is involved, even at facility level, we need to be clear in terms of the reporting time periods so that we don't report late, because once we do that, that information may not be useful, because that's why they have put, and also, you know, they give specific timelines for facilities, districts. It's just to make sure that by the time the nation receives this information, they also have enough time to also clean this information before it is submitted to relevant agencies. Lack of proper data storage and retention. And this usually speaks around the paper-based, as we may see in the subsequent picture. Some sites, the way we store our data, okay? There's poor data recording, filing, and storage system, such that even when we request for this information, you cannot easily access it or find it because you don't know where it is sitting. And I believe for our colleagues like the clerks, they understand what we are talking about in terms of the best practice, in terms of filing and also storage of especially paper-based information. Poor security of records. If there's any place that should be well secured is where data is stored. And I must mention that many of us do not appreciate the value of information that you are generating at different levels. That information should be guarded jealously with the security, because once it can be stolen, or indeed somebody can utter what you have recorded. No plan on how long data will be kept, how it will be disposed. I think in Zambia, we have a policy that is very clear in terms of how long certain information has to be stored and in terms of disposal processing. In addition, we also see that lack of proper data collection or indeed proper lack of proper tools that help us enter the information can also lead to having poor quality data. So this includes lack or indeed unclear system for collection and reporting. Many times we just ask staff to go and sit in and start collecting data without orienting them. So if the staff are not well trained on these various systems, then you don't expect good data to be generated from there. So it's important, and I must repeat, it's very important that staff are well oriented in these various data entry platforms, especially when it comes to smart care. Even in the paper, our registers, okay? If you look at our registers, the standard registers, there's always a key at the beginning. This is to ensure that the information that is entered in the registers are of the same standard, right? Now, if somebody just comes and tells, can you record in this register? Somebody can just put anything that he feels like is right, and it will be very difficult for you to aggregate that information and also to analyze, because there's a lot of inconsistency. Insufficient financial, technical, and human resource. Sometimes there are some facilities where maybe there's only one staff who is supposed to do many tasks and may not have enough time to enter data. As a result, when it comes to backlogging, you may not capture all the information. Human entry errors, yes, these cannot completely be avoided. However, we need to strive to ensure that the obvious errors, entry errors are minimized, especially paper-based. I know under the electronic colleagues and I team have made sure that some of the common human entry errors can be avoided because the system will reject or remind you whether the figure you have entered is correct or not. But on paper, there are no such provisions. And then incentives as well. Some situations where a lot of information has to be entered, especially if it involves community. If there's no motivation, people may not enter data correctly. So what was I talking about? I'm sure, let's reflect where we work from. How is data stored out there in our facilities? Okay, I'm sure many of you are even laughing that, hey, this is how we stored data records at our facility. You can see, if I were to ask you to say, can you pick this and that from there? It will be very difficult, and you can easily lose that information, precious data. This one, we can as well relate to this scenario. You can see one staff there, she's a nurse, okay? She's overwhelmed, okay? She's busy trying to update. I'm sure she's aggregating for reporting, and maybe it's HI1, okay? And she's even telling these people who have brought a pregnant woman who is wailing. So she's telling them, oh, you have to wait. I'm doing my monthly report. I'm sure you can, what do you expect? Do you expect quality data from that? Because if she's alone, she's overwhelmed, okay? So these are some of the issues that we spoke about. Now let's look at this poor quality data that we've been talking about. What effects can it have on the programs, okay? So this poor quality data refers to bad data quality. So if we receive this poor quality data up here, okay, when we conduct analysis, for example, under HIV CBS, when we conduct analysis, our analysis will be done based on the incorrect data, and we may not really send the correct information to the policyholders in terms of what exactly is happening on the ground. Okay, we can as well interpret results that affect public health to be unreliable, and also late or poor reporting to stakeholders may lead to loss of funding. Remember, we need to be accountable. We may as well have missed opportunities to identify gaps or strength in program activities. Good data is important for program improvement. Now, if what is given at your disposal is poor quality data, right? It may not really bring out specific gaps that you need to intervene or allocate appropriate resources. As a result, you may miss opportunities to identify gaps. Waste of additional program resources, this cannot be overemphasized because you'll be channeling resources to a problem that does not even exist, okay? Why? Because you are using poor quality data. This may also involve misallocation of resources. So colleagues, the data that we are generating is very key.
All right, so we pause for yet another poll question. This is poll question number 2. And the question reads, you just pick the statement that is incorrect. So the following are true except, so A, copying errors, transposition, and coding errors are examples of sources of error in data collection and entry. And B, pilot of new forms has no role in ensuring data quality. Then C, treating all received raw data as suspect data values is important in ensuring data quality. Or D, regular scheduled meetings for data review are important for ensuring data quality. So which of the following statements is true? Except, so there is one exception, there is one statement that is false, and you pick which of these 4 statements is false. Is it copying errors, transposition, and coding errors are examples of sources of error in data collection and entry? That is A. Or is it B, pilot of new forms has no role in ensuring data quality? Or is it C, treating all received raw data as suspect data values is important in ensuring data quality? Then D, regular scheduled meetings for data review are important for ensuring data quality. So which of those statements is false? Right, so we still have under 50% participation. Encourage the network to respond to the poll. So I'll give it a few more seconds for more people on the call to respond to the poll. So far we have answers coming in, the majority going for B, right? Some for D, some for C, and some for A. Right, so a few more seconds and then we'll end the poll. We have about 222 connections. So the network, please respond to the poll. Okay, so at this point, I'll just give it a few more seconds. Maybe people from Chipata to respond. Dr. Nyakurira Kandiwo, please respond to the poll. We are waiting for you before we close. All right, so yeah, people from Eastern have responded, so I'll end the poll now and share the results. Okay, right, so you can see from the results, 68% of the network feel that B is the statement that is wrong. That is, pilot of new forms has no role in ensuring data quality. Right, so I'll end the, stop sharing the results and then hand back over to Dr. Phiri to continue with the presentation. We'll see the comments on this poll as the presentation goes.
Thank you. Very interesting post there. And, you know, such questions remind me of med school. If you haven't understood the question well, you might just get it wrong. So we move on. Let's look at some of the common sources of data errors. So this is the question for our colleagues network. What are some of the sources of errors that you think can occur during data entry, aggregation, reporting, that you remember during your practice? So I know many of us have been involved in one way or the other in terms of data analysis at different levels, and some issues should have come out. I want you to reflect and think about some of the reasons or sources of data errors that you came across. And what are some of the best practices you know that may reduce errors to ensure data quality? Okay, so to remind each other, I know some of you had probably came across some of these common sources of error. The list may not be exhaustive, but I think these are the major ones. So errors during collection and entry of data may happen due to transposition, okay? Especially where you have to collect data on a bigger population. So it's easy, instead of writing, for example, it can be form of figures, instead of writing 39, okay? In your typing, you enter 93. Already you are sending a wrong information. So transposition errors, these are usually caused by typing mistakes. I'm sure we can relate to ourselves, even when we are sending messages on social media via WhatsApp, sometimes it can happen that we transpose letters or figures, and this again can happen even when we are collecting data. Copying errors, okay? When, for example, you are copying figures and entering them into another platform, for example, you are transferring information from paper into electronic, it may happen that instead of entering 1, someone can enter figure 7, okay? And one of the common ones on our keypads is that 0 and O. So remember, they don't mean the same. So when you are entering numbers, please make sure that the 0 that you are entering is a number and not a letter O. And this has happened, especially electronic, and during analysis, there are a lot of queries around these figures. So copying errors can happen, and we need to appreciate, and these are some of the areas we need to look at when we are verifying or doing some data cleaning. Coding errors, this may happen when we are putting in wrong code. For example, where you are using a structured interview with codes, okay, where you need to cycle, for example, cycle 1, which is equal to yes, okay, but somebody unknowingly puts the coder 2, okay, the code number 2, which means no. Already the information there is not the same, because what we needed, the response is yes, but unknowingly you will put the wrong code. So during analysis, we'll say this respondent said no. Meanwhile, that is not the case. So this is the kind of error which we refer to as coding error. Consistency errors, okay? This usually happens when we have 2 or more responses on same questionnaire, which are contradictory. So a good example is when we are entering information about, for example, when we are entering information about an individual, usually if you have seen the way we structure the data capturing tool, it usually demands for you to enter the date of birth and also the age, all right? Sometimes even the sex, okay? So for example, if you enter the age, date of birth, like sometimes the system can pre-populate for you. If you don't pay attention, you enter wrongly. And then the age, for example, somebody was born in 2010, okay? And then in age, you write 40 years. So already there, there's a contradiction, okay? And if there's no provision for a data check, that information will go like that, submitted like that. Then the other kind of error is the range errors, where this can occur when a number lies outside the range of probable or possible values. For example, blood pressure or weight of an individual, all right? So the field may demand that you enter the weight of somebody, then you write 500 kgs. Already somebody may question, each human being is weighing 500 kgs, okay? Yeah, so we are looking at the possible values that obviously appear to be outliers. Next. Okay, so what are some of the measures that you can put in place to ensure that some of the data issues that we discussed earlier on and some of the sources of data errors are not happen or reduce? Okay, what are some of these issues? So it's important that in an event you want to bring in a new data collection tool, and the M&E experts are very familiar with this. Before it is accepted everywhere, we need to pilot it, because piloting it means it will give us a lot of information. We'll interrogate it whether it is doing the intended purpose. So even the same registers that are released, initially they're supposed to be piloted before we scale them up down to all the sites. Earlier on, I mentioned that the staff that are expected to input data or collect information at different levels, they need to be oriented. So training is key, okay? Training will actually ensure that we create ownership and belief in the importance of data collection and among the staff that are involved. Also ensure that all relevant staff are trained. This may include data collectors, information officers, program managers. I think this is where some programs may hire data entry clerks. Before they start collecting the data, they're supposed to be oriented so that they understand in terms of what they're expected to do, and also ensure that the necessary practices that may lead to poor data quality are avoided at all means. Encourage routine recording and reporting using standard forms and procedures. So here it's important that whenever site is providing data, you have appropriate and up-to-date SOPs so that there's standardized data that is collected across all the sites. No assumption, don't make assumptions. Emphasize on completeness. On this one, I can say it 1,000 times. This is very important. These data collecting tools were designed in such a way that all the information fields needs to be filled in, because all the data elements that have been put there, they are important, okay? Develop plan for addressing staff turnover. Again, we know, especially our colleagues, the nurses, they usually rotate annually, okay? So as you are moving staff from some sites, because some units within the institution, you understand that a lot of capacity building could have happened in the previous year. And they are so familiar in terms of what happens in that section of the institution. So as you move them around, and actually I would advocate that you don't move them around, but for some reasons, if you want to move them around, there should be a proper transition such that the people that are coming through also, they are familiar with what is happening in that section so that there's no interruption. Next. Furthermore, at data entry, we need to set regular schedule for data review and entry. Data cleaning is key. Data cleaning is key. We'll zero in the subsequent slides. It's important that we treat all received raw data as suspect data values. Don't overtrust, okay? So when even when you are going through the registers, as much as the completeness of the register may be very good, it doesn't mean that the quality of data is high. So treat every data with suspect data values. So you need to check, okay, to see if responses in the fields make sense, right? This is where now we look at the consistency and all those things we're talking about. Is these numbers, are they falling within the range? You look out for duplicates, and also you also look out for completeness and the outliers. It's always good practice that we always maintain the original file, that is unclean data, and validated data separately, because people may want to cross-check and they'll still demand to look at the original data. Many times people do provide data out of fear to say, if we just provide data with a lot of skeletons, they'll come and shout at us, and then what do? You put in the wrong figures just to show completeness, but make sure that the original data sets are kept. Furthermore, at aggregation level, we know that data errors can also happen here. How can we avoid errors in terms of data. We need to ensure quality data should be reviewed, entered, and aggregated on a regular schedule. We need to have good practice in terms of monitoring of data submission rates. And I'm sure this is where we talk about timeliness and completeness. Data should be validated to ensure completeness, accuracy, representation. Feedback should be given to facilities on identified gaps and suspicious values. This is very important that on a regular basis, the facilities that are generating or where the information is coming from at a lower level, feedback should be given and should not always be there when there are gaps. Even when they are doing well, we need to appreciate and give them feedback. This will actually help them do better. Ensuring data quality at storage level and retention. So we need to determine where and how data should be stored depending on the type of data. But as I mentioned earlier on, security should be optimal. Store data according to data types and ensure data is complete. So here, if for example, you have PMTCT or MCH data, let it be stored in one section because it will be easy for you. If you are dealing with pediatric, like pediatric RIT data, let it be in one section, adult, just like that. If it's TB, just like that, because it will be easy for one to pull out and share the information. Determine how data will be kept in terms of security and limit the access. Not everyone should have access to this stored information or data. Where you are able, would encourage that this information should be stored electronically. And I think that's the desire of government to go everywhere. Determine how long data should be kept and also how the data will be disposed. I think these are well articulated by government. In terms of feedback, as I mentioned earlier on, feedback is very important. So data collection size, including districts that are aggregating this data, and they need feedback, all right? This feedback may be in different forms, okay? Sometimes the team may go back to where the data is being collected and just do some verification and appreciate and see, somehow you also appreciate the challenges. So field visits or data audits at facility district can also be used to look at different issues. So we can look at data that is collected and from which source, where and how the data is used, all right? Because the data that you are collecting at size is not just meant for people up, it's also for yourselves to interpret and help you see how your program is running, whether there's need for any interventions where there are obvious gaps. And also it can help, these field visits can help to identify who is responsible for data at both an operational and strategic level. So this can also help to provide a summary findings to the site. So when we, at our different levels, how can we tell that or assess that our data that we are submitting is of good quality? So we can use the famous 3 C's. So quickly we look at our data before we submit. Is the data that we are submitting, that we have collected, is it accurate? Okay, have we validated it? And this is where there's always a part where the in charge has to sign that, oh, we have gone through this data and it's a true representation of what is happening. Completeness. Okay, let's ensure that all the data elements are filled in where possible, and also submission of all the required reports, and also submission, but make sure if it's in the district, all the sites that we are supporting, they need to report, submit these reports timely. Consistency, data within normal ranges. So let's look at our information, our data that we are submitting. Is it within, if for example, it's around in terms of figures, like blood pressure ranges, is this within normal ranges? Okay. Does it also address the population shifts? And also from time to time, especially under HIV program, we understand that with time, some definitions may change just to make sure that they address some of the challenges. For example, some preferred definitions, indicators. So are they, the data that we are submitting, is it consistent with the new definitions? Next. Okay, so so here, I think something's missing. Could be something here. I don't know what has happened, but this just was supposed to help us in terms of how do we look at the completeness of data, and also to depict some of the inconsistency. For example, this is a VCT, okay? So we have age there, 18, and the sex is male, and it's pregnant, yes. So you query, how can this man be pregnant in Zambia, okay? Age 2, sex female. You look at the VCT, 2 years. You may query again here. Maybe this is, there could have been a mistake. Record number, you can see that these, in terms of serial, you can see from 806, go to 807, and then next number is 808. This doesn't match, right? And then you look at some fields which are incomplete. So basically, this summarizes in terms of what we can look out for, even on a paper, in terms of applying the 3 C's. So look at the completeness, okay, is the data accurate also? Consistency, yes. Okay, this is what I wanted, yeah. So under completeness, if the data check is performed daily, for example, somebody responsible to do this at our facility, ask the counselor or staff person to remember that they have a counselor follow up with the patient. So we can look at all those. And we also need to, for example, where somebody said HIV test, you know, the standard or data entry here, there can be yes or no, which is yes, Y, no for. But now you see that somebody has entered X, Y, Z. So you'd want to triangulate the other registers in terms of what is standard, okay?
All right, so we pause for yet another poll question. This is poll question number 3, which should be the last poll question for the session. Right, so the question reads, which of the following is applicable in use of data in Zambia? Which of the following is applicable or are applicable in the use of data in Zambia? Is it A, at subnational level, data can be used to communicate program successes and challenges to policymakers at national level? Then B, data can be used to produce district HIV epidemiologic profiles? Or C, at national level, data can be used to be accountable to clients, donors, and other stakeholders? Or is it D, all of the above? Right, so which of the following is or are applicable in the use of data in Zambia? Is it A, at subnational level, data can be used to communicate program successes and challenges to policymakers at national level? Is it B, data can be used to produce district HIV epidemiologic profiles? Or is it C, at national level, data can be used to be accountable to clients, donors, and other stakeholders? Or is it all of the above? Okay, right, so good response from the network. So far, I'm happy with what the majority are going for. People seem to be using data correctly. Right, so just a few more seconds, I'll end the poll and share the results. Right, so we have over 50% of the network responding so far. So I'll end the poll in the next 3 seconds and then share the results. This time we have very good participation, even Western Province participating. Thank you for that. Continue. Right, so I'll end the poll now and share the results. Right, so you will see from the results that the majority, the network actually went for D. That is, all the statements are actually correct. So we'll see with the subsequent presentation, the correct, yeah, but it seems to be correct. All right, thank you for your responses. So I'll hand back over to Dr. Phiri to continue with the presentation.
Okay, excellent. Thank you. And good observation there in terms of the polling. Learning is taking place. So let's quickly look at the data use. So it is pointless for us to collect information or data without making use of it. So this applies to different levels. So what does data use imply? So this is the process of using data to make important decisions in program planning, policy making, and project management. Okay, this will help to make actions designed to improve outcomes. And I think on several fora, Ministry of Health has encouraged that we need to make use of our data to help us make informed decisions. Okay, so before we decide to use the data, there are quite a number of considerations that we need, first of all, to question. Okay, so we actually use data to make decisions. We need to know before we do that, how is or are data collected? What instruments did we use? Which populations is represented? And how frequently is this data that we are collecting? In what format? Is it electronic or paper? What is the quality of the data? So these questions will help us address some of the obvious expected challenges before we even use the data. So let's look at some of the potential uses of data at different levels. So I looked at the province and district levels. This data, which is supposed to be of good quality, will help us monitor and evaluate programs, track performance indicator targets and progress. So this is applicable to all the programs under HIV, malaria, and others that you can talk about. Compare program planning with data from actual implementation. This is key because every year institutions develop the medium-term expenditure framework, and many times we use data to decide on what areas we need to plan for. So it will be important for us to compare in terms of actual implementation versus where we are, versus what we planned. It also helps us to identify priority needs and emerging problems, make decisions on program improvements, guide and enhance service delivery, obtain additional funding if needed, communicate program success and challenges to policymakers at national level. So these are the potential uses of data at this subnational level, but remember, this is not exhaustive. We can still use data for many other reasons. We can also use it for developing products like epidemiological profiles. It's very important that provinces, districts should be able to produce at a regular time, for example, quarterly or monthly, whichever would be more practical, to produce epidemiological profiles so that whoever visits your districts or province, you have this information timely. Remember, data are useful to the extent that they are analyzed, shared, communicated, and used, not just collected. This is very important. So it shouldn't be an academic exercise, but remember that the information, the data that you are collecting, even at site level, you should be able to help you improve your program and also identify where gaps are. At national level, we can use this data to communicate overall program successes and challenges, to gain additional resources and funding. I can assure you no donor will give you resources without quality data or without explaining your gap using the data. And this data should be of quality or good quality. To be accountable to clients, donors, and other stakeholders, and also to report to policymakers. So data is very key, and these are the potential ways in which we can utilize the data. So in summary, what we have discussed, basically, I lumped it into three. Quality data is important for reporting and accountability, for prudent resource allocation, for program improvement, and also tracking disease trends and policy decision making. We have also learned that data errors can happen at a point of data collection, entry, aggregation, and reporting. So the errors can occur throughout the cascade, and all those best practices that we discussed, we need to implement them at each of these stages. Appropriate best practices to ensure data quality should be applied throughout the data management cascade. This was the last slide. Thank you. So I wish to acknowledge the teams involved. So this is the colleagues from CDC Zambia, CIDAS, MH, CBS team, and University of Zambia team. Yeah, much of the information that we used here were actually adapted from KIDU and DDU. Okay, thank you.
All right, thank you very much, Dr. Chimika, for that well-elaborated presentation. I'm sure we've all appreciated the importance of data. So before I open the floor to questions, comments from the network, we'll just go over again some of the poll questions that we had during the presentation. So we had poll question number 1, right, which was really asking about the statement that was true about data quality. Okay, so the question was, which of the following is true about data quality? Was it A, data accuracy and completeness are important features in paper-based only? Or was it B, data quality is more important for program improvement than tracking? Okay, or was it C, data quality issues includes calculation errors? Okay, right, so the response to this one was C, Dr. Chimika. No?
Yeah, so the correct answer was...
the majority of the network actually got it correct.
Yeah, so the correct answer
is... Then for question number 2 was basically looking at the fourth statement, okay, and which of the following are true, except, so the network can give it a go again to see if learning has actually taken place. Right, so this time 100% so far are going for B.
Yeah, so learning has taken place.
So learning has really taken place. Thank you very much, Dr. Chimika. I think the presentation was well elaborated. Just a few still learning to take place, but I'm sure with more collaborative discussions that we'll have with our panel, more learning will take place, right? Okay, then we had poll question number 3, which was basically asking which of the following is applicable in the use of data in Zambia. So the network again can have a go at it and see whether learning has taken place. Right, so far, everyone is going for D, which, right, so learning really has taken place. I think we have over 50% of the network responding, just under 2% going for D, but the majority, really 98%, have gone for D. So I'll end the poll now and share the results so that the network can appreciate that learning has really taken place. Right, so thank you once more, Dr. Chimika, for that elaborate presentation. I think a lot of learning has taken place with this very important topic. I'm sure some facilities may be different from others. We may be having challenges, but we've seen the importance of quality data because that is what we use to make informed decisions. Because some of the facilities may actually be complaining that no, we receive a very little grant, but maybe it's the data that we are submitting that is affecting such decisions. So let's ensure that the data that we're submitting is of quality data. We go through all the steps that have been presented so that we ensure that what we give is really quality data that can inform very good decisions. And other facilities that are doing well can actually share some of their best practices that have helped them in terms of providing that quality data. So at this point, I'll open the floor to the network before we go into a collaborative discussion with some of our panel of experts that are there. we have Jacob Mutale, we have Dr. Sulani Nyimbili, and we also have Mr. Chimuka Sianyinda as our panelists. So I'll open the floor to the network for any clarifications, questions, or indeed contributions. Over to the network. I can see so far there are no questions in the chat, but there was a comment about whether the slides will be shared. These slides will be available on Slack, the MOH page. So the IT will be able to share that. So colleagues on the network, you can ask your questions. You can raise your hand so that we hear your voice, we interact. Or if you're not able to, you can simply type the question in the chat box. Okay, so we have a lot of connections all the way Western Province. Any comments or questions that you may have concerning best practices to do with data capturing for decision making? I see Kitwe Central Hospital or Kitwe Teaching Hospital now is connected. Dr. Webster Chewe, any contributions that you may have on this very important topic, best practices in data capturing for decision making? Kitwe Teaching Hospital. Okay, I'll move on to my favorite province, Eastern Province, because that's where I come from. Any questions, concerns from our facilities on the Eastern Province? Okay, if you're not able to raise your hand or talk, you can simply type the question or contribution in the chat, and then we'll be able to share it with the network. Okay, I saw Chilenge Hospital connected. Any contributions from Chilenge? You can share some of your best practices. I know there are some areas that you're doing very well. So you can share with the network what are some of those practices that you've put in place to ensure that the data that you're giving is really of quality data. Okay, we have a comment from Dr. Webster Chewe. Good presentation. Sorry, I couldn't unmute. Thank you. We appreciate your participation, Dr. Chewe. Thank you very much for that. Any comments from the other facilities? All right, so we have some of our panelists on the call, Dr. Sulani Nyimbili. Any comments or contributions to this very important topic, Dr. Sulani, best practices in data capturing for decision making? Dr. Sulani, if you're on the call, you can unmute and give your comments. Okay, we have Mr. Jacob Mutale. You can unmute and give your comments on this very important topic, best practices in data capturing for decision making.
Yes, I just have a few comments to make. Dr. Phiri, your presentation was very informative and detailed. I think data quality issues are often talked about, but there's not much in the way of progress that has been made for a very long time. So we need to, I guess, after this presentation, begin to reflect on our own data issues and really start prioritizing, making sure that at individual level, especially if we can make an effort in our various designations to ensure that each individual that comes through the health system their data is complete, either in the file, either in the electronic record, either the lab data or any other data that we have on the patient. If our focus can be directed in that fashion, I think we'll go a long way into fixing some of these issues. I think for a long time, data issues have really been focused at the program level, at the expense of ensuring data quality or data completeness at an individual level. So I think that shift in focus is really going to help us boost our data quality and be able to provide meaningful data for each of our various different programs. Over.
All right, great. Thank you, Mr. Jacob, for that important comment. Really appreciated. Any comments from Mr. Chimuka, Sianyinda? All right, so there are a few comments in the chat. One from Edward Moviana saying the best practice is for the in charge to be verifying the data before it's sent. Any reaction to that, Dr. Chimika?
Yes, I totally agree with the Edward that this is where we talk about honoring the data that you are sending. So we encourage all the facilities before the data is sent, they sit as a team, interrogate the data using all those approaches like the 3 C's. Is the data in terms of correctness? Is this consistent also? And the in charge who actually approve that and commit her or himself that yes, by signing this document, we have gone through it and the data we are sending up is a true presentation of what is happening on the ground. So this is very important. It's not just a matter of signing, but remember what you are signing, you are proving that this data that you are sending is of good quality. But many times, I must say that this is done, but still more, you find the obvious low-hanging data issues that emerge. So I think onus is on the facility charges to ensure that we don't send data that has obvious skeletons.
Thank you. Thank you. And in the similar line, there's another comment from Alice Zulu. My thought is that data should be reviewed by the data team, including the in charge before it's sent. Yeah, in the same line. There was a hand from Enoch Phiri. Enoch Phiri, if you're able to unmute, you can unmute and ask your question or comment. You can go ahead. Over to you.
No, good afternoon. My concern is in ensuring data quality is on the reporting tools, especially the registers. I think this time around, especially the tools that we are using at the moment, there's been a lot of promises, meaning, of course, we know maybe it's issues of fund or procedures to ensure that the reporting tools are printed on time. So maybe my appeal is maybe, that's what I'm thinking, maybe there's been so much issues of lobbying from our partners to help us print these reporting tools. I don't know if we can have at least a specific budget dedicated for these tools, because these issues of draining, the facility staff are collecting data with improvised tools, or maybe waiting for a training or whatsoever. I think we need a very proper backup to ensure that there is no delay in implementing these tools. Because the issue of reconstructing or covering up where we messed up data, it's becoming a challenge. That way, I think it will be a milestone in terms of achieving data quality. I submit.
All right, thank you, Enoch, for that very important comment. I think agreed indeed, having tools really is very, very important, because that is where the data will come from. Even when we talk of quality data, we need those tools that are standardized for every facility to be inputting the data that is coming from the same tools. I think there's another comment from Nangoma Mission Hospital, which is in the same line really to do with tools. Comment is data collecting tools has never been consistent, and most revised registers are rarely available. Hence, most notable errors. So I don't know if some of our panelists can have a comment before Dr. Chimika can come in. Mr. Chimuka, Sianyinda, any comment on that issue to do with data collecting tools, not being consistent in terms of being delivered to these facilities?
Okay, thank you very much, Chair. So what Mr. Phiri echoed, yes, it's unfortunate that we had to do back and forth in terms of procuring of the latest registers. My colleague also, Peter, is also part of the call. He also come in and add on to things. So we are all aware that paper has its own issues. Like he said that when we change our data collection tools, the cost of actually printing is very huge, and sometimes we have to follow certain procedures in terms of the money as well. And one of the reasons we had was we had to move from one office to another to approval to get approval. But in the long run, the move we're moving towards to, like what should mention, is want to go to the issue of the electronic system, because with the electronic system, once we agree on the data collection tools, it's easier for people to be able to send enter using electronic system, and also in terms of the turnaround time for us to start getting the data we want to collect based on the new changes we have made. Also, I want to come back to the same issue Mr. Phiri mentioned on the paper. Actually, the other aspect which has now happened for the ministry is that previously, when it comes to printing of these registers and tools, was being done at a central level. And as you may be aware, that for us to print the whole country, it means you have to, the procedure and the amount would be so huge. So sometimes to go beyond a certain threshold for a certain, let's say for MOH, we have to get authority, for example, from the Attorney General and these higher levels. So the other thing which was now happening going forward, for paper-based, we are going to decentralize the printing of these tools, meaning the provinces are going to take lead and ownership in terms of the printing of these tools. Yes, we agree that for the 2021 tools, we had one or two issues which enabled us not to be able to produce these tools on time. Then also, I also just want to take advantage and also just add one or two things that so far in terms of the data management as a country, previously one of the biggest problem we used to have was data completeness in terms of people completing data, sending data on time. At least there's been some steady progress with regard to data completeness and timeliness in terms of how long does it take for the facilities to be able to send to the province, to the district, sorry, and for the district to be able to input in the DHIS so that the province and national level would have access to our data. The other area of concern, which we need also to just work hard as a country, is when it comes to the issues of data use. Much of the data quality also comes into play because it's more of the push arrangement of our data. So one of the areas I think also which is an appeal to our colleagues at the lower levels is the way we have done very well with the issue of being able to send data on time, and also this we are trying very well in terms of sending complete data. But the issue of consistency and correctness are not, we have not done very well on the 3 C's Dr. Phiri was mentioning, because mostly it's the issue of collect the data, send them to the district. The district probably also aggregate the data, send to the province. Many times we don't realize that that data is also useful at our level. So at this point, I may allow my colleague Peter to also come in and add one or two things, Chair. I submit.
Thank you, Chair. My name is Peter Funsani with the Ministry of Health and M&D. So I think in addition to what Chimuka has pointed out, One of the other means that we've put in place as a ministry, working together with partners such as CDC and USAID and DOD, is the fact that the Ministry of Health with its partners do what we call the data alignment exercises. So a data alignment exercises are really a reconciliation between the HMIS data and the data that is reported to the partners that I've mentioned earlier, and also the data that is largely into the smart care. So the data alignment processes have been going on for the past 3 or 4 years, I should say. And over time, you realize that the data disparities or the data gaps between the PEPFAR reporting systems as well as the HMIS reporting systems have really narrowed down. And as such, this exercise has been, or rather it is now being decentralized from being a national level exercise to much more of a district level. So moving forward, I think starting September, it should be a district level exercise where the districts are able to do the data alignment, the districts and the provinces, they're able to do the data alignment processes that is on a quarterly basis, trying to check between those two particular systems. So that's one of the areas that which we've also put in place to address the issue of data quality, as pointed out earlier. I submit, Chair.
All right, great. Thank you for those comments from Chimuka and Peter. Probably the two can still give a comment on this question that is in the chat from coming from Kitwe Central Hospital. Are you able to update us when the government or Ministry of Health shall adopt an all paperless medical records, especially in high volume facilities like Kitwe Teaching Hospital? Any comment on that one, Mr. Peter Funsani? Any comment?
So thank you, Chair. In terms of timeline, I know I may not give a definite timeline, like maybe by next year or the other year, but we need to really appreciate that the ministry is using the dual systems of data collection. That is the paper-based as well as the electronic. And in some of those high volume facilities where the smart care is not fully fledged, there's an intermediary paper, a hybrid of paper as well as a tech system that is being rolled out as well. And we're calling it the smart, the SPT, the smart paper technology. So it is the smart paper technology really is a bridge and a transition between the hardcore paper technology and the hardcore electronic. So we're bringing in a bridge so that we have that smooth transition, and the pilots of that SPT should start next month, May, if not June, in Lusaka. Then we'll move accordingly like that. But I think it suffices to mention also that for the electronic medical records, the system of choice is the smart care, and the strengthening is still going on in terms of rollout of other modules such as the MCH, which has been enhanced in this recent patch that is being rolled out into the facilities. So we may not have a definite, I may not give a definite answer. We are taking to ensure that there's a smooth transition as opposed to a surgical way of doing things. Over, Chair.
All right, thank you. That's well received. Thank you for that comment. So there's another from Justin Lubinda. This is just a comment on the issue of using smart care to report side by side with DHIS2. They're saying it's difficult as its use is poor in most facilities. Is there any reaction to that, Dr. Chimika?
Yes, thank you. And I agree with Justin in terms of the underutilization of the smart care in most of these facilities, but I'll throw the question to Chimuka. Chimuka, do you want to comment, or Peter? Why I'm saying these are the technicals in terms of M1E. Yeah, so there's a concern that DHIS2 versus smart care being used at the same time. It's a challenge.
Yeah, so Chair, I think
we seem to have lost Chimuka, but there were some hands raised. Probably you can, in the interest of time, you can probably type the question in the chat box, then we'll read them out as Mr. Chimuka tries to get back on the call. Or any response from Peter?
so
Mr. Peter,
this is Funsani. Yeah. So I was saying
yes,
that yes, I was saying that in responding to which system do we use, whether smart care and the DHIS2, I think Director M&D has been categorical that where the smart care system is functional, we use the smart care system. But it also suffices to say that in the smart care, you are able to generate the HIA2, which is a main report for services into the DHIS2, as well as the HIA1, which is also a main report for diagnosis in the DHIS2. So the challenges that arises most often than ever is that smart care, you find that it's only fully functional in one area, for instance, ART. So it leaves out some of these other services like child health, maternal, reproductive, and so on and so forth. So that's where facilities tend to do a mix of both systems. But where it's e-first and the smart care is fully functional, the directive has been, we use only one system, which is a smart care, to report onto the DHIS2 in terms of the HIA2 and HIA1 report that is generated from the smart care. I submit, Chair.
Okay, thank you, Peter, for that response.
Sure, I want to just add on what
yes,
Peter has just said. So I think the other point is, I think the person who asked the question, like what Peter has said, DHIS, it's in form of, for lack of better way, just HIA2 and HIA1 form, which is just electronic. So I think what maybe our colleague was trying to confuse it to is, for example, when it comes to HIV, we may have registers and smart care. So I think, like what Peter was mentioning, the guidance now is that you cannot have registers where you're capturing people in a register and also entering smart care. You need to choose one of the two to be able to capture the data. So in this case, it will be electronic system. But if we're trying to compare smart care and DHIS, I think that's why we have a problem, because like what Peter was saying, smart care is able to generate HIA2, and what facility they do actually is that they will go to smart care for those who are doing those who are not using registers for ART, for example, and they just enter into smart care. At the end of the month, they will go and run the HIA2 where smart care will generate the numbers for ART or HIV services, and they would indicate on the HIA2 form and be able to submit to the data like the facility. So I think what we need to differentiate is that smart care and DHIS can exist, but where the problem comes in, unless where a facility wants to use smart care and the registers, that's why we are encouraging, like Peter said, that we only need to have one system, either use the register or smart care, but electronic system takes precedence. But smart care and DHIS, they can coexist because the other one is patient level leveled information system, and you're also able to get aggregated numbers, which we can input. In case Peter just forgot to mention, actually, the long-term plans are that smart care should be able now to transmit the data that would have captured into DHIS2. I think Southern Province, we have been trying to pilot those innovations. So in terms of smart care and DHIS, they can coexist. I think one of the issues are those to do with the registers and smart care, where we have to just choose one, and also a current system takes precedence. I submit, Chair.
Thank you very much. The network, we have come to, it's 16 hours on the dot. So before we close, I would just like to echo some of the summary key points that we've had from this presentation that was made by Dr. Chimika Phiri. The first one was that quality data is important for reporting and accountability, for prudent resource allocation, program improvement, tracking disease trends, and policy decision making. The second one was data errors, of course, can happen at any point of data collection, data entry, aggregation, and also reporting. And lastly, appropriate best practices to ensure data quality should be applied throughout the data management cascade. So in the interest of time to our network, thank you very much for this wonderful participation, and to our panel of experts for that collaborative discussion. And thank you to our didactic presenter, Dr. Chimika Phiri. Thank you for coming through to the hub and giving this wonderful presentation. To our network, thank you for participation. We've actually come to the end of the session. It's 2 minutes past 16. Just a reminder on the next ECHO session that we're having on advanced HIV disease. It will be this Thursday at 12 hours, and we'll be looking at severe bacterial infections in advanced HIV disease. That is narrowing down to pneumonias, bloodstream infections, and also infections of the central nervous system in advanced HIV disease patients. So once again, thank you to our didactic presenter, Dr. Chimika Phiri, and our panelists that took time to join us today. And lastly, thank you to the network for this wonderful participation. We'll meet next, this coming Thursday with the ECHO on advanced HIV disease, looking at severe bacterial infections. Once again, thank you very much. And from us at the UTH Hub, it's goodbye for now. We shall meet on Thursday. Again, thank you very much and goodbye to everyone.
Thank you.
Thank you.